Today I will discuss on acute kidney injury. I am Dr. Partha, nephrologist. One case scenario: 27-year-old male encountered on road traffic accident, developed right femur fracture. After some time was taken to a local hospital. Their blood pressure was not recordable. The patient received IV fluid, injection diclofenac sodium, and antibiotic amoxicillin and clavulanate. After some time, after some stabilization, he was referred to a higher center. And when he reached to that higher center, blood pressure was 90/60. His urine volume was around 20 ml per hour. On the day of admission, creatinine was 1.2. Next day, it rose to 2.5. Hemoglobin was 7, and patient needs surgery for the right femur. So, if you see in this case, this patient had kidney dysfunction because creatinine rose from 1.2 to 2.5 and patient was oliguric. So whether this patient has acute kidney injury or this patient has chronic kidney disease or acute on chronic kidney disease, from the case itself you have to understand and accordingly you have to treat. Now obviously in this case it's very obvious that patient had an acute insult in form of road traffic accident uh, and trauma and hypotension. So obviously in this case the diagnosis is very clear: acute kidney injury. Whether background chronic kidney disease is there or not at this point of time, that is immaterial, but the treatment should be directed for acute kidney injury. Now what is acute kidney injury? Is an abrupt and usually reversible, very important, usually reversible decline in the glomerular filtration rate. So acute kidney injury is an abrupt and usually reversible decline in the glomerular filtration rate, GFR. What are the causes? In a very simplistic way, or a simple way, we can categorize whether it is a pre-renal, means before kidney, causes uh, affecting the kidney, but the causes are the before kidney, when pre-renal, or renal, which directly affects the kidney, and post-renal, which is after the kidney, anatomically after the kidney. So pre-renal. Pre-renal is decreased GFR due to pre-renal disease occurs into two situations: when kidney ischemia is part of a generalized decrease in tissue perfusion. So in this case scenario, it's a basically pre-renal kidney ischemia. This 27-year-old man encountered road traffic accident. Patient developed hypotension. It is a generalized decrease in tissue perfusion. Along with that, kidney ischemia also has happened. But some other diseases where there is a selective kidney ischemia. Example: renal artery stenosis, renal artery thrombosis, etc. Next is acute tubular necrosis. When this hypotension remains for a long period, then the kidney damage, the ischemia, can lead to acute tubular necrosis. So, prolonged and or severe ischemia can lead to ATM. This can result in histological changes, including necrosis. So, if we do kidney biopsy, we will see uh, necrosis with denuding of the epithelium and occlusion of the tubular epithelium by cast cell debris. Cast means when the cells are shed out, they go to the tubule. There is a fluid in the form of urine, and uh, based on this pH and albumin, they gets precipitated and forms cast. So different cell forms different cast. So that is acute tubular necrosis. I hope this is clear to you. So pre-renal and acute tubular necrosis. So causes of pre-renal disease. So in pre-renal disease, you may have true volume depletion, like in this case, the blood loss. You know, the femur fracture can cause large amount of blood loss. So true volume depletion and hypotension. Acute diarrhea, severe diarrhea like cholera also can produce this kind of uh, volume depletion and hypotension. However, there are other causes which can have edematous state, but still the kidney perfusion is poor. Example, heart failure. The heart pumping is poor, so that blood doesn't reach to the kidney effectively, adequately. So heart failure, but there is a lot of edema in the body, water accumulation. So in heart failure, you will have edematous state, but you may not have good kidney perfusion. Similarly, cirrhotic and also nephrotic syndrome. Uh, in cirrhosis, you know that splanchnic vasodilatation happen. So effectively, organ perfusion comes down. Nephrotic syndrome, severe hypoalbuminemia will have third spacing, so lot of edema from outside, but intravascular volume may be low, may be high, or may be equal. Uh, in next class, we may discuss that. But in general, nephrotic syndrome more so if the patient gets a lot of diuretics, patient can have uh, very low intravascular volume. Next is selective kidney ischemia and others drugs affecting glomerular hemodynamics. Suppose painkiller that can cause glomerular hypertension by effectively constricting these uh, efferent arterioles or ACE inhibitors or ARV, etc. Now, causes of acute tubular necrosis. Three major causes of ATN is kidney ischemia due to hypotension, sepsis, and nephrotoxic drugs. Now, coming to the renal. So far we discussed pre-renal, now renal. Renal, you may have intrinsic renal vascular disease. I would suggest you to think everything in very simplistic way. Like a kidney has structure like glomerulus. So when you think glomerulus, it has afferent arteriole and efferent arteriole. Before afferent arteriole, there is the branches of the renal artery. So renal vasculature is there, then glomerulus there, and after glomerulus there is a tubule and interstitium. So any disease, whenever a patient comes to you, any disease you think in this anatomical uh, uh, way, like whether this is renal vascular disease, renal glomerular disease, or renal tubular or interstitial disease. So that will help you to find out what kind of disease the patient is having. Like Intrinsic renal vascular disease, intrinsic glomerular disease, nephritic pattern, nephrotic pattern. Nephritic pattern, they have uh, high blood pressure, edema, reduced urine output, proteinuria, and hematuria. But this proteinuria is not large enough like nephrotic uh, range. So next is nephrotic pattern. In nephrotic pattern, there is a large amount of proteinuria, that is nephrotic range. All nephrotic range proteinuria do not produce nephrotic syndrome. To have nephrotic syndrome, patient must have severe hypoalbuminemia uh, causing large edema. They may or may not have hypertension. Generally, they do not have hypertension, and the urine is generally bland when there is no active sediments. Intrinsic tubular and interstitial disease also can cause kidney disease. There are many causes that are like, again, painkiller can cause, then PPI can cause, any and many antibiotic can cause. Different diseases like sarcoidosis, tuberculosis can cause, even vasculitis also can cause tubular and interstitial disease. Otherwise, renal stones, hyperuricemia, hypercalcemia can cause this kind of diseases. And the last is the post-renal, means there is some disease after kidney. So post-renal disease is general obstructive uropathy. It may be bilateral or may be uh, unilateral. So if one ureter is blocked either by stone or by papillary necrosis, papilla, or intrinsic obstruction or obstruction from the outside wall, also can cause can cause kidney disease. If it is bilateral, generally it has to be below the bladder level, at the bladder level or below that, like prostate or uh, neurogenic bladder, uh, etc., where the the urine is not urine is not cleared properly, there is an obstruction. Sometimes we do see renal stones bilateral. It's rare, but we do see. It's not that we never have seen. Bilateral sudden renal stone causing bilateral ureteric obstruction, causing severe renal failure, and that recovers with removal of the stones or removal of the obstructions. So clinical examination is extremely important to find out whether this patient is having hypovolemia or hypervolemia, uh, failure, heart failure, ascites, nephrotic syndrome kind of things or not. So blood pressure is important. Sometimes you may not get clear idea of hypertension uh, until you do postural blood pressure checking and find out there is a drop in blood pressure. So that's important. Otherwise, in general, you will get hypertension uh, for pre-renal and ATN in ATN, initial part of the edema is important. Pallor. If patient has pallor, like this patient, case scenario we discussed has pallor. Otherwise, there is some other disease like hemolytic uremic syndrome or TMA, thrombotic microangiopathic. So there is a blood hemolysis, and they develop anemia. So, presence or absence of pallor is important. Jaundice, even like malaria causing acute renal failure, will have jaundice. Again, HUS may have jaundice. JVP. High JVP is obviously suggestive of heart failure, and like in cardiorenal syndrome, you'll have JVP high. So you can match whether this patient is having pre-renal or renal. Now, systemic examination is important. So I'm not going into detail. because one systemic examination can give you a clue with what kind of kidney disease patient may have. So investigation, the urine analysis is most important. This is called poor man's kidney biopsy. So normal or near normal in prerenal disease unless it is superimposed on another cause of kidney disease. Hyaline and or fine granular cast may be seen, but these are not an abnormal findings. It's maybe in a normal also. ATN reveals muddy brown granular epithelial cell cast and free renal tubular epithelial cells. The absence of this urinary finding does not exclude ATN, and their presence does not always establish the diagnosis of ATN. Means if it is there, it is a suggestive and also can have nephritic pattern or nephrotic pattern as already I have discussed. So this is a photograph showing urine sediment with muddy brown granular cast. You can see here. So this is taken from the up to date. Another investigation is fractional excretion of the sodium and urine sodium concentration. Uh, FENA is the preferred test for distinguishing between prerenal and ATN. The urine sodium concentration tends to be low in prerenal disease. Obviously, in that situation, kidney proximal tubules wants to preserve the uh, sodium, so reduce the sodium excretion so that the blood pressure goes up. So it is a defense mechanism by the kidney in an appropriate attempt to conserve sodium, and urine sodium is high in ATM, where the tubular epithelium is damaged. No more can preserve this, absorb and preserve this sodium. So if it is more than 40 to 50 milliequivalent per liter, it's in favor of ATN. Uh, so in part to impair tubular function induced by tubular injury. So FENA in prerenal it is low and it is ATN it is high. So FENA percent, this is how to calculate urinary sodium and serum creatinine divide by serum sodium and urinary creatinine into 100. So other investigation like to do complete blood count, see hemoglobin is low or high, then WBC counts high, uh, there is an infection out there, and platelet count is low or not. In many kidney disease, you may get low platelet, which will help you like a hemolytic uremic syndrome or TMA. Now, peripheral smear, a good peripheral smear can give you a lot of uh, information like cystocytes when fragmented RBCs are there or not, uh, uh, like abnormal cells, malignancy is there or not, plasma cell is there or not, which will direct towards some other disease which can have secondary effect to the kidneys. Now complements. Now sudden onset glomerular disease, uh, we must do complement C3, C4, if possible CH50 also, and based on that reports you can have idea what kind of kidney disease, glomerular kidney disease this patient has. Urine culture, urine routine, urine protein excretion estimation by spot urine protein creatine ratio are important investigation for evaluation of acute kidney injury. However, if you are sure from the um, clinical idea that this patient may not have uh, other diseases, then all the investigations are not required except urine routine. So serum protein, calcium, uric acid, APS, PPBS, and RPS, those are also important investigation. And another is ultrasound. So in ultrasound, generally we do ultrasound kidney ureter bladder to see whether kidney size are normal or not, cortical thickness is good enough or not, or how is the cortical echogenicity, and is there any obstruction or not. and if it is there obstruction, at what level. So these are the investigation for acute kidney injury. Now this is a very clumsy slide. You go through in details. Is basically is a staging criteria for the acute kidney injury based on the rifle criteria, acute kidney injury network criteria, and KDIGO criteria. So in everything, in every criteria, there are basically by definition that two things are there, whether creatine goes up or not. In generally, they suggest that if creatine goes up by 0.3 milligram per deciliter or more than 50% of the baseline, and if urine output is less than 0.5 ml per kg body weight for 6 to 12 hours, 6 hours, um, and uh, the for staging, um, uh, for rifle, there is like risk, injury, failure, loss, and end stage. So go through this slide in detail. You will understand, and there is very important implications of this kind of definitions. So treatment part is basically you have to resuscitate, maintain the blood pressure by giving fluid, uh, and whatever fluid is available in your hand, first you give that. You can give a normal saline or balanced diet, and if ultimately if you need the dialysis, then you have to find out what are the condition when you need the dialysis. One is uh, pulmonary edema. In spite of doing everything, if the after even giving Lasix, urine output is not good. Lasix means furosemide or torsemide, urine output doesn't improve, and patient needs removal of the fluid on urgent basis. So you do dialysis and remove the fluid. Second is hyperkalemia. In spite of uh, giving medical management like furosemide, acidosis, and then uh, uh, calcium gluconate, uh, then K-bind resins. In spite of that, sodium bicarbonate, in spite of that, if potassium level remains high, they are prone for cardiac conduction abnormalities, then we have to do dialysis. Signs of uremia in forms of pericarditis or an other unexplained decline in mental status, do dialysis. Severe metabolic acidosis, pH less than 7.1, and hypervolemia, unless acidosis can be rapidly resolved by quickly correcting the underlying etiology. Suppose patient is having severe hypovolemia and acidosis, so give fluids and see whether acidosis gets corrected. However, if the patient already you have given fluid has developed hypervolemia, pH remains low, uh, and if you give more soda bicarbonate infusion, more fluid, then patient will go into pulmonary edema. So uh, instead of doing further such medical management, it's better to do dialysis. And any kind of acute poisoning which needs dialysis, you have to do dialysis. So these are the indications of dialysis. This is a very short video. uh, I'll be happy to answer your questions. Thank you very much. Thanks, and go through the slides, and I'm ready to discuss further. Thank you.